Okay, well, let's go ahead and get started. Let me first just thank you for joining on the webinar today. As I mentioned in the email, this has been approved by the Florida Bar Association for 1 hour of CLE credits, and I'll have the information with the updated course and my CLE provider number and all that good stuff at the end of the presentation, so you can document this for your records. So again, thank you guys and gals for joining. I'm Dr. Jonathan Walker, CEO of Ethos Health Group in Florida Spine and Injury. We've got offices in a dozen different locations across the state. The Florida Spine and Injury offices are in Ocala, Gainesville, Lake City, and the Villages. And then Ethos Health Group, we have locations with medical and physical therapy providers in Daytona Beach, Melbourne, Tampa, Lakeland, Sarasota, Sun City Center, St. Pete, and Palm Harbor. So a lot of different plates spinning and a lot of things to keep moving here, but the topic of today's webinar is understanding traumatic brain injury, and we're going to go through the proper diagnosis, documentation, and imaging, because I think a lot of this is getting missed. And so one of the most frustrating things that I commonly hear from the personal injury attorneys, paralegals, case managers, etc., that we work with is TBI really just kind of getting swept under the rug, so to speak. And I'll talk about some reasons as to why that is, and most importantly, what we can do about this, because there is a huge population of people who you trust as their legal counsel that they're telling you the truth. When they report these symptoms and they say they're getting dizziness, they're getting headaches, they're getting nausea, blurred vision, double vision, memory problems, and you believe them. And the challenge is that the imaging technology doesn't always catch up with the true nature of these injuries and their symptoms. And so we're going to talk about some different types of imaging that have come down the pipeline that will allow us to uncover and really understand these injuries in ways that, 5, even some cases just a couple of years ago, we really didn't have the ability to do. Now, I have wondered for a long time why it is that these things get missed. This is my opinion, and it's just that, it's an opinion, that traumatic brain injury is probably the most underdiagnosed injury in motor vehicle collision or whiplash cases. And there's a lot of reasons for that, but it's cool because beyond my opinion, there actually was a case report that was published and gave some really good, I think, speculation as to why so many providers, whether it be treating chiropractors, whether it be family doctor, ER physicians, orthopedic doctors, etc. Why does traumatic brain injury and the different manifestations, why do they get missed? And so this paper, which I'd be more than happy to share, actually some of you have seen in the research updates that I've put out, you've seen I did kind of a write-up on this paper. And so some of you already have this, but if not, please feel free to shoot me an email. I'll provide you with all my contact information here, and it's also in the email that you receive from me. I'll be more than happy to share any of the references you see in the presentation today. There's going to be a bunch of them. Be happy to share any of those with you. So the first thing that they speculate as to why this gets missed is that there's no loss of consciousness report. And many providers, they assume, well, if you didn't lose consciousness, then you must not have had a traumatic brain injury. And so they said that the lack of loss of consciousness does not correlate with severity of TBI or chronicity of attendant symptomatology. So it's interesting that not only does it not correlate with the how severe it is, meaning you can have a very severe brain injury where there was no loss of consciousness, or in many cases there can be brain injuries that people recover from fairly quickly. You think of if you're a fan of football or boxing or MMA, these people get knocked out cold and they return to competition relatively soon thereafter. The second, and I believe one of the most significant, is incomplete imaging studies. Typically, the CT scan is usually the first order of imaging that is done for traumatic brain injury cases. Sometimes down the road, MRI is done. And so the study said standard MRIs have 6 millimeter unseen slices due 6 millimeter unseen slices due to standard MRI cervical protocol, which includes a section that is skipped to save time. Since the Chiari was 5 millimeters, this could be why it was missed. What on earth does that have to do with brain injury? Well, we'll talk about that as we go down the presentation of what I call an orthopedic brain injury. Now, understand that's a term I made up. So if you Google orthopedic brain injury and nothing comes up, it's because I made that up. This is a type of injury that is called a cerebellar tonsillar ectopia, also known as a tonsillar herniation. You see here the reference to Chiari. Some of you have seen that before. Chiari, or Arnold-Chiari syndrome, is a congenital brain problem. And so what this is saying is that this type of what was previously thought to be purely congenital can actually be caused by trauma. We're going to dig into that. But the point is that this type of orthopedic brain injury, or tonsillar herniation, gets missed because of the thickness or lack of specificity of the type of MRI that's being done. And then the third thing that's speculated as to why these brain injuries get missed is a lack of provider training. And again, this is not indicative of any one specialty. This is something we see, unfortunately, across the board. Doctors, whether it be chiropractors, physical therapists, nurse practitioners, MDs, DOs, there just seems to be a lack of provider training in brain injury. And so the authors of that paper speculate another possible reason for misdiagnosis is lack of knowledge, experience, or training in the arena of TBI, and it leads to an inability to recognize related or atypical signs and symptoms and improper evaluation and assessment. And the challenge comes that a lot of these folks present first to either a chiropractor or to maybe some type of a rehab-based physical therapy clinic, and they're presenting with these symptoms, but if they're not documented, they're not delved into, by the time they get to a neurologist, however many months later that can be, there's not what I call the breadcrumb trail, meaning there is not documentation of ongoing the dizziness, the memory problems, the blurred vision, the double vision, the nausea. We'll talk about some of these symptoms and how important it is that they're simply documented. Now, this is not a rare, never happens issue. There's about 1.5 million cases of MTBI reported annually in the United States. Now, obviously, not all of those are coming from, motor vehicle collisions. Someone just asked, is there going to be a PowerPoint? You should be seeing my screen here. So can everybody else see my screen? David, I see your question, but let me make sure that you can. That was at 12:59. So that may have been right before I shared the screen. Okay, so hopefully everyone else can see my screen here with these images. Okay. Let's see, my apologies. Okay, good, I can see the screen. All right, this will prevent my low-grade ADD from kicking in here. All right, so 1.5 million cases of mild traumatic brain injury annually. And these aren't just from motor vehicle collisions. These come from sports injuries, military injuries, assault and abuse, domestic abuse situations. But it's something that really is a significant public health issue. Now, it's interesting because when we talk about mild traumatic brain injury, should we actually refer to it as mild? That seems to be almost kind of pejorative in terms of the severity of the symptoms that come with traumatic brain injury. So understand, when you hear the word mild, when you see this in your notes from healthcare professionals, you may have adjusters or defense attorneys who don't fully understand this, and they tend to kind of minimize, oh, it says it's just a mild injury. Mild has some definitional criteria. So mild means a loss of consciousness less than 30 minutes, Glasgow Coma Scale of 13 to 15, post-traumatic amnesia less than 24 hours. So if you have someone who's injured and they're knocked out on the pavement for 25 minutes and they don't remember their wife's name for 20 hours post-trauma, definitionally that was a mild traumatic brain injury. So you understand as legal professionals that words have power. So I want you to understand that when you see the term mild or MTBI, that does not speak to the severity of the symptoms, the impact that it has on their impairment, their disability, their enjoyment of life, things like that. It simply is based on these. Think of it as a spectrum from someone who is like a comatose or a vegetable to someone that has truly just a very transient, very mild situation. So understand that that's kind of how this is being viewed. Now, the most common myth that I think is out there in brain injury world is that this only occurs with a blow to the head. That, well, Dr. Walker, they didn't hit their head on the dashboard or the door or the steering wheel or the the window, so I don't buy that there could be a brain injury. And I've had this conversation before. Now, a TBI without contact, many of you know this to be a fact, this is very common. We probably see more non-contact TBI in my offices than we do contact traumatic brain injury. And the best way to think of it is kind of like an egg yolk. If you shake and shake and shake that egg hard enough, the shell won't rupture. The shell didn't hit anything, but you can really mix up that yolk. Some of you have done this around Easter, trying to get the yolks out of the middle for eggs with your kids. And that's obviously not a perfect analogy, but that is kind of what we see with what's called a coup contra coup concussion. This is one of the most unfortunately common scenarios this arises is with shaken baby syndrome, where the brain gets thrown backwards and forwards at a very high rate of speed and kind of sloshed along the walls of the skull. This is a great diagram that comes from one of Art Croft's posters. He's with the Spine Research Institute of San Diego. And you see here in red are the areas of high pressure. So across the top of the head, and then right here around the base of the skull and the top of the neck. And we're going to circle back to how important that is, because that's a significant portion of these injuries that I think more than any is what's getting missed in the typical workups. Now, the threshold of a probable cerebral concussion, meaning how fast does someone's head and neck have to move for us to be able to reasonably say that there was potentially a concussion. And so that threshold, the literature has shown, is around 1,800 rads per second squared, which means absolutely nothing to anybody who is not an accident reconstructionist or a biomechanist. To put sort of some teeth to that, one study found that a 13-mile-an-hour frontal collision produced these forces. So let's talk about this for just a second. I won't go deep in the world of accident reconstruction and occupant kinematics, but this is interesting because that's a frontal collision of 13 miles an hour. Now, modern bumper thresholds, depending on the manufacturer, can range anywhere from 10 to 15 miles an hour in order for the bumper to be deformed. So 13 is in the range where potentially you could have a 13-mile-an-hour frontal impact and, depending on the type of car, not even have any visible damage to the bumper. What's more significant is that a 13-mile-an-hour frontal collision, the forces that are transmitted in that type of an impact are going to be on par with a rear-end collision closer to 8 to 10 miles an hour, because we know in a rear-end collision, the occupant kinematics, or the forces to the people in the vehicle, are very different. When you get hit from the front, there's what's called a monophasic curve, meaning you get hit from the front, and the head, it goes boom, boom, goes forward and then backward. You get hit from the rear, it's called a biphasic curve, because in about a quarter of a second, 250 milliseconds, the head and the neck first goes backwards, then forwards, then backwards again. So we know that someone is subject to much more force and much more trauma in a rear-end collision than in a frontal collision. So the point is that 1,800 rads per second squared, that threshold, if you will, can potentially be hit in a rear-end collision of only even 8 to 10 miles an hour, which is considered to be a low impact collision. And I'm not sitting here in la-la doctor land telling you that it's easy or that it's even, it's even possible in some cases to establish someone had a concussion and somebody low for a fact, because you've seen it done. You've personally handled, litigated some of these types of cases. So I just want to give you an idea of some of the physics and some of the forces that are at work here. All right, now when that brain gets thrown around the inside of the skull, there are sharp edges inside that create a lot of damage. It's not, the brain is not encased in this smooth skull. You look inside the skull, there's all kinds of little ridges and nooks and crannies that the brain gets essentially thrown against when it's moved very rapidly. And then that diagnosis, as we discussed, is often missed. What we try and do with all of our offices, and this is some extensive training that I put all of our providers through, whether they're medical providers, chiropractic providers, nurse practitioners, etc., is making sure that we're asking the right questions and that we are diagnosing. We could do a whole nother presentation on the 86 different claims adjusting software programs out there. Most of you have heard of Colossus. There's also Teach, Mitchell Medical, etc. The most effective way to get information uploaded into those software programs is for there to be a diagnosis and for that diagnosis to be put in the actual medical records. And so traumatic brain injury has a code with the ICD-10. Acute post-traumatic headaches, there's a code. There's an ICD-10 code for chronic post-traumatic headaches. For dizziness, sleep disturbance, and this, by the way, can mean lack of sleep, or this can mean hypersomnolence, which refers to sleeping too much following trauma. Nausea has a code. Anxiety has a code. Depression has a code. So you can see how easy it is to have a really long list of codes just from the neck up. And this is one of the most effective ways that I think is missed by most doctors, because we're not trained in chiropractic school, medical school, osteopathic school, what have you, to think in terms of how the codes are necessarily painting a broad and accurate picture for an insurance adjuster or for an attorney. We're trained in terms of just giving the most concise answers to the question of what's wrong with this patient. We want to make sure that we document all of these symptomatic codes, even though they're all related to that same traumatic brain injury code. It helps to paint the picture of the breadth of symptoms. So how do you document these properly? Well, the first step is just asking questions. On the initial assessment, we leave a lot of time. It's part of our kind of algorithm that we go through of we start with the history of the accident. We then go to whether they were seen at the ER, family doctor, kind of who they saw next. And then the third step in our flow is tackling all the brain injury symptoms. Have you been experiencing, Mr. Jones, any headaches, any blurred vision, any dizziness, double vision, nausea, ringing in your ears, problems with balance, memory problems, concentration problems? We ask these questions because what we find is a lot of patients, if the questions are not asked of them, they assume, oh, those headaches, oh, that's just coming from my neck, which it may well could be, but we don't know. Or they assume that the dizziness and the nausea, and oh, that's coming from the muscle relaxers that they gave me at the hospital, which it may well could be, but we don't know unless we dig into this. And so we find that people, they often cases don't throw this stuff right out there until you really start to dig and ask the right questions. And so we then document this with what we call our peer-reviewed neuropsych testing. And that sounds really impressive, but essentially what this is a battery of peer-reviewed tests. I didn't come up with these things, so they're very easy to defend as far as a reasonable standard that can be used to document the different deficiencies. So the first thing we use is called the Folstein Mini Mental State Exam, the Folstein. And so it has a variety of different questions on here. Tell me the date, where are you, going down to memory recall, things like that. The second form is called the ACE, the Acute Concussion Evaluation Form. And this is a good symptom inventory, kind of a checklist, if you will. And this also gets into some of their history, because we know that people that have a history of brain injury are going to be more disposed to having future injuries with less less force or less trauma involved. Next, we give them the Epworth Sleepiness Scale. And so this rates on a 0 to 3 scale their chances of dozing in various scenarios. And then probably my favorite is the Rivermead Post-Concussion Index. And so the Rivermead rates it as 0 of not experienced at all to 4 is a severe problem now. Now, one of the things that's helpful, particularly in areas like Sun City Center or the Villages or Ocala, heck, anywhere in Florida where we have a big geriatric population, is no more of a problem now than the access. That's important. She was explaining to me that she had blurry vision and she had trouble remembering things and she was losing track during conversations, and I'm thinking, TBI. And I asked her, I said, and ma'am, all this stuff you've described, this happened, after the accident you were involved in? And she looks at me and she goes, oh, no, honey, I'm 85 years old. I've been dealing with this for years. And so it's important to make sure that we don't, attribute every problem somebody has to the brain injury. If some of these things they may have been suffering before, and we have to determine, was this an aggravation of a pre-existing condition, or was this simply just she was 85 years old and had some cognitive issues? So that's why the Rivermead can be helpful in thoroughly documenting that. And so this is really about just, like I said, kind of creating the breadcrumb trail, so to speak. And then we have a more comprehensive neuropsych eval that can be sent, can be referred out for. A patient can be sent out for a neurologist, or depending on the market that we're in, some markets it's easier versus others to find a neuropsychiatrist or neuropsychologist. Most markets, we can find a neurologist who is reasonably competent and comfortable handling these brain injury cases, because we know that if this is going to be a significant injury that's part of the litigation process, having those specialist second opinions is significant and important. Now, let's see here. You know what? Let me talk for just one more about a slide that I think was kind of left out here. The other thing that we will do as a part of our workup is a testing called C3 Logics. C3 Logics is a computerized cognitive test. It was developed at the Cleveland Clinic to be used for a variety of different head injuries, both in documenting the deficiencies as well as a baseline testing. So you give it to a bunch of football players before the season. One of them gets a concussion. Well, you know what his baseline was before. So the C3 Logics program measures short-term memory, measures reaction time, measures what's called executive function, and also measures balance. It's actually iPad-based, and it uses the very sensitive accelerometer that's in the iPad to very easily and quickly document these things. And so C3 Logics gives us a significant amount of data that we can utilize in our evaluation process. And like I said, it was developed in conjunction with the Cleveland Clinic and used in various settings across the country. So that's just one more tool that we have in the toolbox, if you will. Now let's talk about the imaging, because I know this is the stuff that we can diagnose it, we can document the symptoms, but we live in a world, especially as juries become more and more affected by the CSI expectations that everything fits in a nice, neat little box, that it can all be easily shown and proven. Anything that we can show objectively from an imaging standpoint is a good thing. So let's talk about a couple of types of imaging, because the typical, the PET scans, the SPECT scans, CTs, T1, T2 MRIs, they're often inconclusive. I would venture to guess probably even more often than not, these are inconclusive. So there's two types of imaging that have come to the forefront, and some of you have heard of these. Some of you, I'm finding more and more, even have some firsthand familiarity with these. You may have had cases where this type of imaging was ordered. But if that's the case, many times I have found that no one's really sat down and explained, okay, well, that's cool, but what does it actually do? So the first type of MRI is called diffusion tensor imaging, or DTI. This is a picture of it that you can see here with all these really cool purples and greens and things like that. So DTI is tracking the movement of water throughout the brain. Now, water is produced as a byproduct of normal neuronal metabolism. And so this type of DTI study is also known as fractional anisography, but it's basically measuring water as it's moving about. Now, this is really helpful because water basically gives us kind of a roadmap of the brain. So it's easy for us to be able to see if the patterns or the flow are moving as they should normally, or if there's some kind of edema or swelling, particularly on a more subtle, less appreciated level. They're not in danger of dying from this. But if the swelling is affecting the flow of water, if it's squeezing it off, if you will, it's kind of like looking at traffic. You look at I-75 when it goes from 5 lanes down to 1 lane. It seems to be every time I drive to Tampa, that's the case. You could fly above that in the helicopter, and you could very easily see that traffic is not moving. A way to look at the brain and say, wait a minute, traffic is not moving as it should. And there have been some pretty significant studies on this. This one I like because this is looking at, it's called a meta-analysis, meaning it's a study of other studies. And so this examined 100 articles on DTI. And their conclusion was that 100 articles met the inclusion criteria, and that DTI effectively differentiates from patients with TBI and controls, and then follow the statement at the end, regardless of severity and time frame following injury. So this is also important because some of you have cases sitting on your desk right now that they've kind of gotten neglected. And we know that if a brain injury is indeed a permanent brain injury, that these findings, they're going to show up, as you see here, regardless of time frame following injury. This is a study that looked at DTI and post-concussive symptoms 6 weeks following the brain injury. And it said there were significant differences, and don't worry about what mean and radial diffusivity, that's basically just the patterns, when they compared the post-concussion group with the trauma control group. That meant people who'd been in trauma but didn't suffer a concussion. So you can see differences. DTI is often paired with SWI. SWI stands for susceptibility weighted imaging. Now, SWI is another type of MRI, but it's measuring something very different. So SWI is detecting microhemorrhages or brain bleeds, basically, because it can pick up on iron deposits. Iron is found in hemoglobin. Hemoglobin is found in blood. And so this gives us the ability to see brain bleeds that are much, much smaller and more subtle than what you would typically look for on a CT scan. So a CT scan, if you're sitting at your desk and you've got a pencil eraser, it's about 5 millimeters. In a CT scan, we'll see a brain bleed that's about 5 millimeters in diameter. These SWI studies, which, by the way, when you see here A and B, this is the same patient. Okay, so this just shows you the difference in what the right type of imaging can pick up with CT scan versus the right type of brain MRI. And so the SWI, susceptibility weighted imaging, can see brain bleeds that are roughly the width of about 30 strands of hair. So we're talking several orders of magnitude in difference between what a CT picks up versus what SWI can pick up. Now, let me back up here. This image that you see on the right, you see here we're under B, this is not going to be the typical normal that you'll often see from a brain injury. This is probably a stroke patient where it's very widespread and very localized. These are the types of things that you'll probably see much more commonly. So you see here the same patients, their CT scan on the left, and then the SWI study with an arrow pointing to that little infarct up there in the frontal lobe. These are the types of things that you're going to be catching with SWI. This is also some examples of the types of lesions that you can see. And then the cool thing is that this can actually show diffuse axonal injury. I remember I did this presentation, it's probably been about 3 or 4 years ago, to an attorney, and he said, oh my, he goes, we were taught that diffuse axonal injury can only be shown on autopsy. Well, the good news is that may have been true if you were relying on, a traditional CT scan, but we can now show diffuse axonal injury, or axonal shearing is another term that you'll see utilized much, much more effectively than we've been able to in the past. And here's some studies that talk about SWI, and this is from the Journal of Neurotrauma. It says it may provide additional sensitivity in detecting lesions after TBI. And so it may provide a more accurate representation of the severity of individuals' injuries and their subsequent neuropsychological outcomes. This is another article on, this one's published in 2009. Susceptibility weighted imaging is extremely sensitive for the visualization and detection of microhemorrhages. So think of it as seeing little bleeds, almost like scabs in the brain. That's not exactly what they are, but kind of, that are missed with traditional MRIs. All right, so treatment options. I remember I had a attorney who for years he had worked on the defense side, and just recently in the last couple of years started doing plaintiff work for a plaintiff litigation firm. And he was kind of confiding in me and kind of frustrated in a client that he had referred, neurologist options in terms of people that are real comfortable with PI cases. And so we referred this patient to, I think it was either Tampa or St. Pete. And the client came back kind of mad at him because the neurologist they saw didn't do anything. And he said, basically the neurologist said, yeah, they're definitely injured and it definitely came from this car crash. But he goes, but Dr. Walker, and I started laughing. And, man, what did you do for brain? Really good diagnosticians. They're really good at figuring out what's wrong, but they really don't do much typically in the way of treatment. There is no magic pill or magic treatment that they're going to recommend. And he goes, oh, I guess I never thought of that. And so that's so frustrating for not just you, but for your clients, because they don't feel like, one, they don't feel like they're being validated. Sometimes people are telling them they're crazy and, it's, quote, all in their head as opposed to it's, a true brain injury. And secondly, nothing is being done. And I find that even if it doesn't provide a, rapid miracle type of relief, if clients see that treatment is being performed for them and they have some hope and some, glimmer of expectations that they're going to be able to change, that can be really, really important in terms of lifting their spirits and kind of helping them feel like there's a light at the end of the tunnel. So the first thing that we utilize is called AlphaStim. AlphaStim was developed with Department of Defense grant money for soldiers with traumatic brain injury, post-traumatic stress syndromes, things like that. And AlphaStim, as you see here in the picture, clips on, it's an older model that's in the picture, but clips onto the ears, and this is providing transcranial electromagnetic stimulation. Now this, I swear, is not shock therapy. So this is nothing that we're, putting a wood clamp in people's mouths and turning on the juice. This sends a very, very gentle stimulation. Matter of fact, they don't feel anything when it's initially turned on, but eventually we tell the clients, or excuse me, the patients, the way that we calibrate this is when they start to feel just a slight, almost kind of disorienting, like when you're on a boat and you feel it moving just a little bit, that's when we know that we're producing alpha waves, and then we back off just a bit. Now, alpha waves are what your brain produces during prayer, during meditation, during deep restful sleep. These are happy waves. And so this is a way of producing more healing, soothing, happy waves in the brain. And it's a very safe treatment. It's not very expensive. It bills with the same code that electric muscle stim bills. So this is a great option. It's small, it's portable, very, very good to use for these patients. The second thing that we utilize in our Ocala location is what's called neurofeedback, or EEG biofeedback. And this is a really, really cool technology. We could go into a whole lot of detail with it, but basically this is an EEG that is measured on a quantitative level. So the first thing we do is called a QEEG, or a quantitative EEG, and this measures their brain waves and compares them to people across the world in a database that are the same age and same sex. It tells us what's firing too low, too high, which brain waves are about right. That tells us what areas we need to treat. And so the way the treatment works is, let's say we're trying to stimulate the frontal lobe in the front part of the brain. So we'd have a surface electrode that sits right on the skin, doesn't even poke anything into the skin, but it sits right on the skin. And that's hooked into a device which is attached to a laptop. And the patient has a set of goggles that they're wearing that are gently flashing different colors of lights depending on what part of the brain we're trying to treat and whether we're trying to elevate the brain waves or calm them down. And we know that the eyes are the windows to the soul. That sounds very romantic to say, but the eyes are the windows to the brain. And I think most of you know this, how significant the eyes are when it comes to assessing the brain. That's why, a police officer, when they're looking at a DUI stop, they're measuring, one of the things they look at is eye movements, because that tells us a lot about the brain, specifically the cerebellum. And so those are stimulating. The glasses that they're wearing are stimulating the brain. Well, how do we know if it's doing its job properly? That's where those surface electrodes come into play, because the patient is watching a movie on the laptop. If their brain is producing the waves we're attempting to train, the movie stays on and the sound stays on. If they're falling into the, call it, injured patterns, the movie starts to fade out and the sound starts to fade out, and the brain doesn't like that. It's like when you walk into a room and the ballast is messed up and the lights are flickering and it drives you crazy. So the brain says, whoa, 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 what do we need to do to try and get that good, steady stimulation back again? So that's where for heart rates, things like that. This is called neurofeedback. And this is something that we use. I would say about 80% of our patients that we use this with experience significant benefits with it. And so this is a really, really nice option to have for patients that are injured. The code bills to PIP. We're probably one of the few offices in the state that is doing this on auto accident cases. And so, we had to just really honestly fight them for the first couple of cases. When I sent them the exhaustive, list of the literature, and they saw that Medicare pays for this, they backed off pretty quickly. But this is a great code that we utilize. One of the other simple things, and this is something that someone can start immediately, is high-dose EPA-DHA supplementations. This is taking very high doses of omega-3 fish oils that are potent with EPA and DHA. This is an area that we're seeing in a lot of athletic settings that they're recommending for athletes that want to get back to competition, to take very high doses of omega-3 supplements in order to try and decrease some of the inflammation at the brain level. And let's see, this is one particular study that talked about the utilization of omega-3 fats to alleviate the risks of traumatic brain injury. All right, so what I want to do is transition for the second half of the presentation And I apologize if I'm talking too fast here. I get excited about this stuff, and so if I'm talking too fast, I'll be available for plenty of questions at the end of the presentation if you've been jotting down notes or anything like that. But I want to transition into the second type of brain injury, which is what I call an orthopedic brain injury. Now, before we talk about an orthopedic brain injury, I want to give a little context, a little background as to how the spinal ligaments, particularly the craniocervical ligaments, how they actually lead to this type of orthopedic brain injury. We discussed that with the brain being pulled, literally sucked out of the skull. Now, let's talk about ligament trauma first and kind of set the stage. So I don't look at spinal ligament trauma as just a, quote, soft tissue injury. I look at it as a torn ACL in the spine. Now, an ACL tear can be partial. It can be complete. You see a complete rupture outlined in the MRI on your screen. But suffice to say that an ACL tear is a significant injury. No one disputes that. However, it's an injury that's relatively easy to diagnose. It responds fairly well to surgery. Nowadays, 8 months later, we've got high-level athletes back doing things that the rest of us can't even fathom doing. And in many cases, it does not leave a lot of permanent, ongoing, debilitating injuries. Now, let's compare that to partial tears or complete tears in the ligaments in the cervical spine. They're what I like to call the 3 Ps. They're painful, some of the most highly innervated with what we call nociceptors. Those are pain-sensing nerves in the entire body. So it's a very painful injury. It's progressive. It gets worse with time. I was just reviewing a study yesterday that talked about how osteoarthritis in any joint is the consequence of lack of proper ligament stability, whether that's the knee joint or whether that's the spine. So it's painful, it's progressive. And then the third, the worst, is that it is permanent. So these types of injuries are not typically amenable to surgery. Some of you in the Tampa Bay area are familiar with Dr. Joel Frank, who's a neurosurgeon that has pioneered a C1, C2 fusion procedure for severe cases of upper cervical instability. That's not readily done for most of these injuries because there either is not enough instability or they don't have access to someone like Dr. Frank or adequate insurance coverage to pay for what is a very extensive and expensive surgery. But the point remains that the same soft tissue injury in the knee, when it's in the neck and it's more painful, it's more permanent, it gets worse, and it's not amenable to surgery, suddenly it's kind of swept under the rug as just soft tissue. And I think the reason is that we've not had objective proof. And the insurance companies have known that and had that leverage to say, well, how do we know they're not just making this stuff up? And so this is where we now have MRI evidence of soft tissue injury. Now, there is a Norwegian researcher, Dr. Jostein Krikines, who is kind of like the godfather of cervical soft tissue MRI. And so, what Krikines and his group did was say, wait a minute, when we're doing a protocol for, let's say, a shoulder specific type, it's called proton density MRI with fat suppression sequences. And he said, wait a minute, what if we apply that to the neck, to the cervical spine? And so that's what they did. And so they discovered that there were very common changes, particularly in the upper cervical ligaments. The ligaments across many of you have heard of the ALL and the PLL, anterior longitudinal ligament and posterior longitudinal ligament. Those run across the front of the spine and the back of the spine. The challenge with those is that they're really, really thin. It's almost kind of like the fascia or the gristle on a piece of steak. And so it's very, very difficult to see direct striations or direct changes in the anterior longitudinal ligament, the posterior longitudinal ligament. The way we know those have been ruptured is when we do a flexion extension X-ray or MRI or a DMX, a digital motion X-ray, and we see those bones slipping and sliding forward, anterolisthesis, retrolisthesis. That's how we know the ALL and the PLL are injured. This is referring to the upper cervical ligaments, the transverse ligament, the alar ligament, the posterior atlanto-occipital membrane. And so they found that, sure enough, we could see these things on MRI. So this was published in the journal Neuroradiology. It said high signal changes of the alar and transverse ligaments are common in whiplash-associated disorders, or WAD 1 and 2. And then here's the kicker, unlikely to represent age-dependent degeneration. This is another study published in the journal Spine. This is considered to be the world's most prestigious orthopedic spine journal. And they found that these lesions are indeed caused by whiplash trauma. And again, I'm kind of blazing through some of these, but if any of you ever want to get into more detail, I'd be happy either on a hop on a call with you, or even to do an in-house lunch and learn with your firm, and we can walk through some of this in more detail if you'd like. But I'm trying to give kind of the 30,000-foot view here. So this study indicates that, strongly indicates that whiplash trauma can damage the tectorial and posterior atlanto-occipital membranes, and I'll show you some pictures. This can be shown on high-resolution MRI. Probably my favorite reference is this one because it's a textbook chapter. This was written by Dr. Keynes in the textbook Medical Imaging. And they found that whiplash injuries can cause substantial signal changes in craniovertebral ligaments and membranes. And these lesions, especially in the alar and transverse ligament, are associated with pain and disability. So it's not a non-specific finding, like arthritis. Sometimes osteoarthritis leads to pain, sometimes it doesn't. It can be very non-specific. They found that you don't just sit down or plop into a chair or step off a curb, some of the favorite defense doctor analogies, and whoop, ruptured a ligament or partially ruptured a ligament. There has to be a very specific type of force involved to do that. Our bodies were not designed to be thrown around in motor vehicles or what have you at high rates of speed. The analogy that we use with our patients in the course of normal treatment is we take a piece of silly putty and we roll the silly putty up and we show them if you stretch silly putty slowly, it'll stretch and stretch and stretch and stretch, but doesn't tear, and it still remains intact. You take that same piece of silly putty and you snap it quickly and it'll rupture. That's what's called viscoelastic properties. Ligaments are highly viscoelastic. So the ways that they rupture or the ways that they deform are very dependent on the degree of acceleration. And acceleration doesn't typically occur in normal day-to-day life the way it does when you're rear-ended, even if it's only at 8 or 10 miles an hour. Let's see, this is in the Journal of Neurotrauma, and they found that the worse the lesions were, they had more pain and disability. So there's a correlation there. All right, so let's talk about the anatomy a little bit, and then we're going to get this back to brain injury. So this is a view from the side. This shows the anterior atlanto-occipital membrane and the posterior atlanto-occipital membrane. This is literally what holds the base of the skull. You can see, my pointer's probably not showing up real well. This is the occiput. This is the back of the C1 vertebrae, the top vertebrae in your spine. And so this is what holds them together. Now this is a normal patient. This is non-trauma. You see where those arrows are pointing. And this is what the literature refers to as the thick black stripe appearance. So this is a thick, uninterrupted membrane connecting and holding those two together. Now this is a trauma patient. And you can see where I've got those red arrows pointing. And that's, by the way, something that we can very easily put together with these arrow illustrations for purpose. But you can see how it's black up at the top where the first arrow points, it's black down here, and then where that second arrow points, it's been ripped. Now, this membrane, the posterior atlanto-occipital membrane, is almost pure elastin. And the point of that is it's really strong. It's like duct tape. Duct tape doesn't really stretch. Duct tape, it tears or it's intact. And that's what we see with these membranes, is that you can have some partial tearing of the posterior atlanto-occipital membrane. These are the alar ligaments. A lot of you have heard of the alar ligaments because people, I was just on the phone with an MRI rep up in Jacksonville today, and she was talking about, oh yeah, we do the alar protocol. So the alar ligaments, I actually don't recommend calling those type of MRIs the alar protocol, because the alar ligaments they're very small, they're oriented in different directions on different people, and their morphology or their makeup is kind of unique. So they're actually very similar to the ACL. They are a collagen core surrounded by an elastin sheath. Now, why does that matter? Because the ACL is prone to what I like to call kind of funky striations. The ACL is prone to changes that show up on imaging that may or may not be indicative of trauma. And so what do? They correlate it with their physical exam findings, where the provider moves their knee back and forth, and whether it's athletic trainer, surgeon, what have you, and they can feel it, it's either stable or it's unstable. This is where we have to correlate potential alar lesions. We have to correlate them to things like the A to T open mouth lateral bending x-rays, where you can actually see when someone opens their mouth and bends left and bends right, we can see the C1 vertebrae slipping off of C2. This shows up the most vivid on a digital motion x-ray or DMX study, because you can change their positioning in real time, have them open their mouth a little wider, make sure that they're square and straight ahead so you're not getting rotational distortions. So anyway, I don't recommend couching the alars as our end-all be-all injury unless we also have the corresponding biomechanical changes that make sense, which is why, as a matter of protocol with our cervical trauma patients, we have them do the initial flexion, extension, and lateral bending x-ray views so we can assess this. So this is a normal alar ligament on MRI. In between those arrows, you see where it's kind of black and pretty consistent all the way through. You see here on the left, it's black out towards the top, and then right there near the dens is that plug on the C2 vertebrae. We see that it's kind of a gray color. Depending on your resolution and your monitor, sometimes this shows up easier than others. This is why, you know, for trial purposes or deposition purposes, I like to have this on an iPad or a tablet, because it's sometimes, depending on the lighting in the particular room or courtroom or what have you, or the quality of the projector being used, these are, you know, they're more subtle, versus having it on a tablet or having it on an iPad where you can, you know, see what the resolution is very easily. Makes a lot of sense. And so this is an illustration I had made that shows kind of what the tearing looks like, because the reason that these ligaments show up with that gray, sort of a mottled color, remember black is healthy, gray is not healthy, is because gray is what they call the high signal intensity changes or high signal changes you saw in the literature mention. And that comes with fibroblasts, that comes with swelling, that comes with edema. That tells you that that ligament was injured. And so gray is not normal, black is normal. This is a slide from a electron microscope. We see up top, that's what normal ligament tissue looks like. You see at the bottom, this is post-traumatic ligament tissue. It first looks like a bundle of kind of fibers or, you know, strands of yarn. The second looks like someone took a sweater and ripped it wide open. Down here at the bottom, this is why your clients are in pain when they've suffered motor vehicle trauma, because these ligaments aren't just in the neck, they're down in the facet joints in the lumbars, they're in the thoracic spine, they're all throughout the spine, the sacroiliac joint. This is a different type of histology slide that I call the bacon versus hamburger slide. So it's after lunch, so hopefully this doesn't gross anyone out. If it ruins your lunch, I apologize in advance. But you see here the facet capsules. So when someone does a facet block, they're trying to anesthetize the pain that comes from tearing of the facet capsular ligaments. So you see it looks like bacon, kind of a nice even striation. Post-traumatic on the right, look at you. So this is the patient that's going to respond well to a facet block. At our Ocala location, we have an interventional spine specialist. He is a physiatrist, Dr. Jolu, that is wonderful with the epidurals, facet blocks, radiofrequency ablations, things like that. And so these are patients that will likely respond well to those sort of interventions. We talked about the transverse ligament. I mentioned that briefly. So this is the transverse ligament. We're looking up from above down on the top of the spine here. And so this is a normal, healthy transverse ligament. You see that black all the way through. And then this is a trauma patient. It's black right next to the dens, but then you see out at the margins where that arrow is pointing, where it says light gray. That light gray represents swelling, represents injury, just kind of like you see in this illustration. All right, now we've set some foundation. Hopefully you've got you know, some areas of interest with ligament trauma. But what does ligament injury have to do with brain injury? This is that non-Chiari cerebellar ectopia, non-Chiari, because this is not a congenital injury. And even if it is, even if you get an adjuster or you get someone that just digs their heels in and says, I don't buy it, that this came from trauma, I think this is congenital, we're talking about a massive potential aggravation of pre-existing conditions, because a Chiari malformation is where someone is born or develops early in life a problem where the cerebellar tonsils, the base of the brain, you come with the mouse right here, so you can see right where I'm circling here, that's the cerebellar tonsils. This line right here, this is the occiput, this back of your skull, this white part right here. So if I were to draw a line right across here, that's right at the bottom of their skull, and you see how there's brain matter hanging out. Now, even if they want to argue this is pre-existing, so you mean to tell me that, you know, my patient's driving down the road, minding their own business, born with something they can help where their brain is hanging out of their skull, and they get rear-ended, and it smashes the cerebellar tonsils back and forth against the inside of the skull, and you mean to tell me that's not a significant injury? So there is a firm in Chicago, and I need to look up their name, that they specialize in Chiari-related litigation. So if someone does have a pre-existing Chiari malformation, they are a very, very brittle plaintiff because they're someone that is going to be susceptible to more injury. But I'm going to show you why I believe that these are not typically pre-existing, why these can be traumatically induced. This is a fairly common finding with whiplash cases, and this is one of my favorite articles of all time when it comes to understanding my patients better. And this is a huge case study. Michael Freeman, who many of you have heard of, he is a very expensive expert witness, considered one of the leading authorities in the world on motor vehicle collision occupant injuries. And they looked at a huge case study. We'll see here in just a minute, 1,200 patients. So they split them into 600 trauma, 600 non-trauma. So 600 people with whiplash, 600 controls. They then took those and they broke them up into scanning them recumbent, so on a regular lay-down MRI, and then scanning them on an upright MRI. And what they found is that about 5.5% of people, when they scanned them laying down or sitting up, in the non-trauma group, about 5.5% of them had this finding. So again, there are people that are just, you know, born this way. That's called Arnold Chiari malformation. Incidentally, that 5% number is kind of funny because that also is what the literature shows for an asymptomatic cervical disc herniation. So about 5% of people are walking around with a herniated disc in their neck, and they're asymptomatic. They don't know it. So I just thought that was kind of unique. But what that means is that 95% chance that cervical disc was caused by some type of a trauma, or that person is going to be feeling, they're going to have pain, it'll be symptomatic. So 5.5%. Now, when they scanned them in the trauma group, they scanned them laying down, they found that that number doubled to 9.8%. When they scanned the trauma group upright, you see here, 23.3% of people had this finding when scanned on an upright MRI. You see in the picture here a Phonar upright magnet. This is why we are such proponents in markets that patients have access to it. You know, for example, my Lake City office, guess what? There is no great MRI option for trauma patients in Lake City, so we have them go to Jacksonville. My Ocala office, we send them down to Claremont. Our offices across the Tampa Bay area, there's several good in Daytona. So in my humble opinion, it is well worth patients traveling to have this done because you get 3 findings for the price of 1. You get the regular discs like you would see, like herniated discs. You get to see the craniocervical ligaments we just talked about, and you get to see this tonsillar herniation brain injury finding. So that was 4 times as prevalent in the trauma group versus the non-injured subjects or the control group when you scan people upright. That to me was significant. And so this is an injury that I find is not being talked about enough. And part of that comes from the radiologists because they see this and they're like, it's a mild Arnold Chiari malformation. Number 1, it's not mild. Number 2, when it is a true Arnold Chiari malformation, we see that the cerebellar tonsils, that part of the brain, to have kind of a cone-shaped appearance. Let me back up here. Okay. So down here, you see how it's kind of a cone shape? Hopefully you guys can see this okay on your screen. Let me give just a second for the slides to catch up. Okay, so you see here kind of that cone shape. And now I'm going to jump forward. Oops. Oh, this is a new paper. I just found this one. I added this one in here. This is tonsillar contusion associated with benign tonsillar ectopia following minor head trauma. And so this case suggests that cerebellar structures is not limited to overt tonsillar herniation. Benign tonsillar herniation may predispose to cerebellar contusion even after minor concussion, and thus has clinical significance. So this is saying that even though someone may have had this finding pre-existing, but then they get some type of trauma, this can really significantly cause, as you see here, tonsillar contusions, or the brain banging against the foramen magnum. That's the hole at the bottom of the skull. All right, so this is an interesting image you can see here. This is looking at a slice from the side, and in blue, that arrow represents the base of the skull. That's the foramen magnum. It means big hole. It's a really great Latin term. And so beneath that big hole, so underneath the blue line, you see all of that brain matter right here that's hanging out underneath their skull. Now, I have a 9-year-old, a 7-year-old, and a 4-year-old, and of course, my kids are brilliant and wonderful and perfect, just like all of your kids are, especially at those ages. And I guarantee my 4-year-old, I could show him, his name is Hudson, and I could show Hudson, now, Huddy, do you see that blue line? He'd say yes. And do you see, is that gray stuff, is that below the blue line or is that above the blue line? And my 4-year-old could tell you that blue line has gray stuff below it. This is an interesting case. This is a lady who was in a grocery store, and this was sent to our office out of state, actually, from a firm in Kentucky that I lectured at a postgraduate conference, and a doctor heard this, and he went, this is my patient, meaning this patient represented what I was speaking about, all the symptoms I talked about. He goes, this is what my patient has. And so he sends the lady down to, she was at a grocery store, and she was going to get a cake off the shelf, and someone pushing a hand cart loaded with soda, one of the distributors, parks it right behind her. And so when she turns around, that cart's there, trips head over heels, and she smacks her head on the ground. She's 68 years old, so the MRI shows, the cervical MRI shows bulging discs. Well, congratulations, she's 68. But she had all the symptoms that we associate with this tonsillar herniation. Because when the tonsils are pulled down, it obstructs the normal flow of cerebrospinal fluid. That's what the brain floats in. And so you get dizziness, you get blurred vision, you get positional headaches. That's the most significant. We call it the pathognomonic finding. When someone says, man, I'm laying down, my headaches are better, but when I sit up, holy Moses, it gets worse. Because the tonsils are getting pulled down into that hole and they block off CSF. So sure enough, we scanned this lady, we sent her for an upright MRI. This is the worst one I've ever seen. And this, you can see, has kind of a rounded sort of appearance back here. So this is how I'm confident that this was not a pre-existing finding she was born with. And even if it was, there's not one scratch on any of her medical records indicating that these symptoms were things that she'd ever reported before 68 years on planet Earth. This is a axial slice, and you can see where those arrows are pointing. That represents brain matter clogging up that base of the skull. This is another way that you can illustrate this fairly easily. In green is the base of the skull. In blue, this is the cerebellar tonsils. And then in yellow, we see here, that's the line that represents the bottom of the skull. So if any of the blue stuff is hanging below the yellow line, that's not normal, that's not good, and that's bad. This is a coronal slice. So this would be like the patient's nose is coming out of the screen at you. And so we see in green here, that represents the base of the skull. In blue, this represents the cerebellar tonsil, the bottom of the brain. And then again, you see where it's below, where that yellow line is, we see that it's specifically on the right-hand side. Because remember, their nose is coming out at you, so the left-hand side of the picture means the right-hand side of their brain. And so we can see it's the right cerebellar tonsil. All right, now how does this happen? And then we're going to land the plane, and I'll leave some time for questions if you've got some Q&A here. Whoops, my laptop's getting a little froggy. Okay, so the first thing that has been theorized is that rapid pressure changes can cause damage. So when we're swinging the brain back and forth, remember picture in the beginning with the red area at the top of the head, the at the bottom, that those rapid pressure changes can damage. The dura mater, that's the Latin for tough mother. It's the outside of the spinal cord, the outside of the sac that surrounds it. That can actually be torn during flexion extension trauma, causing the CSF to leak, causing the brain to kind of drop down. But that's actually not where evidence is pointing to us this most likely comes from, because tearing of the dura is fairly uncommon. What this really comes down to is the loss of stability or rotation of those upper cervical vertebrae. So all those ligaments I showed you, they help to hold the vertebrae together. Ligaments are torn, either partially or in rare cases completely, then we lose normal spinal stability. Why is that important? Because the spine attaches to the spinal cord. The one connection that we have between the central nervous system and the skeletal system in the spine are these little bitty ligaments called the dentate. You see right through here in the picture, these little guys over here and over here, these are called the dentate ligaments. You can see right there. So we've got the spinal cord is attached to the spine via the dentate ligaments. So if that means if the bones are twisting, guess what that's doing to the spinal cord? It means it's got some torsion placed on it as well. Now these dentate ligaments are downward oriented, meaning they're slightly kind of diagonal. And so it's like a Chinese finger trap. When you twist the bones, it pulls down on the spinal cord. The spinal cord is attached to the brain, so it pulls down on the brain. When you pull down on the brain, you obstruct the normal flow of CSF, and that leads to these crazy symptoms that we've talked about that, you know, some of your clients, you start to wonder yourself, like, what on earth is wrong with these people? The neurologist said they were normal. The MRI showed that, you know, there was no disc herniations. The EMG NCV testing showed there was no, you know, major nerve compressions. Most cases, they're not making this stuff up. It's coming from these types of pathology that are typically missed. All right, so I've talked at like 100 miles an hour here. So I want to go ahead and open up for some questions, and you'll type those in the questions box. Let me pull that up so I can see them coming through. Okay, give me just a minute. All right, so you see on there the course number and the provider number for those of you that are going to be keeping track of this for your CLE credits. As I shared with you before, we have offices in 12 different markets. We're actually looking at expansion into some others, but that's not going to be until next year because I'm tired of opening offices. We've opened a lot recently, and it's kind of stressful. So one of the things that we do that I think is, you know, very unique from a communication standpoint with the law firms we work with is we have an attorney records portal. So anytime that you want to access your client's medical records, instead of having to wait on us and, you know, wait for this stuff, we actually give you an attorney records portal. And so you have access immediately. We update them on a weekly basis to not only all of our records, whether medical, therapy, etc., but also image records, the billing ledger updated weekly, and then also any specialists that they've seen. So we get hospital records. That means you don't have to. We get records from all the, you know, whether it's neurologists, pain management, neurosurgery, things like that. Okay. All right, so I don't see any questions coming through here. Let me give you guys just a minute to type those in. That means that this is either really, really great and I answered every single possible question, or I just talked too fast. Let's see here. Okay, someone asked, can we get the case law case studies? Not exactly sure. If you could clarify exactly what that means, what you're talking about, I'd be more than happy to share that with you. Case law or case studies. Yeah, if you just send me the whatever specifics that you need as far as case studies, I'd be more than happy to share the different references and literature here. And as far as you know, anything from a medical standpoint, I'd be more than happy. But we have not had any issues with, from a, you know, whether it was a Daubert challenge or a Fry challenge, any of this stuff not meeting evidentiary standards, there actually is an attorney that some of you have worked with, many of you have heard of in the Tampa market, Matt Powell, who has handled probably more cases than just about any lawyer in the state of Florida with the upper cervical, this craniocervical stuff, the brain injury, things like that. So let me go ahead and give you my contact information. I'm going to put this up on the screen. Let's see here. And so my email is drwalker@flspineandinjury.com, and that's my cell phone that's up there. I am in the kind of CEO administrative seat, so I'm much more accessible than most providers as far as making sure that you guys have everything that you need and being able to answer questions. I'm actually in Daytona Beach right now with my in-laws celebrating the Thanksgiving holidays. So any of you, if there's any attorneys or case managers on this call that are in Daytona and want to get together over the next couple of days, I'd be more than happy to meet some of you face-to-face, because there was a lot of new names and new faces on today's webinar. But if you've got any questions or there's anything I can do, all of our scheduling is handled centrally through the Ocala office. And so we take care of scheduling. That's always done on a same-day basis. And then we do provide transportation as well in all of our markets, whether that be in-house transportation or utilizing Uber and Lyft and things like that. So we really want to make sure that we get these folks taken care of as quickly and efficiently as possible, because a lot of times they've got unique challenges when it comes to just getting to the office and coming in for treatment. So, oops, let me back up here. Okay, very good. So I don't see any other questions coming through. Let's see here. So yeah, Tanya, you had asked me about some of the case law or case studies. So just shoot me an email at that address and let me know which of the particular ones that you would like, and I'll be more than happy to share any of those with you. And if any of you have follow-up questions or would just like to get together to learn more about working together and what we do at Florida Spine and Injury and Ethos Health Group, please reach out to me, shoot me an email, shoot me a text, and really appreciate everyone joining and very attentive, as I can see here, through GoToWebinar on today's call. And we'll be doing a lot more of these. I've got about a dozen different presentations that we've got in the pipeline with the Bar Association for CLE credits. And if you'd ever like an in-house presentation or a private webinar, I'm more than happy to arrange those and get those set up as well. So thank you so much for everyone for your attention, and I look forward to meeting a lot of you that I've not made acquaintances with face-to-face. Hope everyone has a happy Thanksgiving, and we'll talk to you soon.